This week on the BackTable Podcast.
The reality is, if you're having a procedure with a 10% chance you're going to come back to the ER, that's not great.
Yeah.
And, we institutionally, I think a lot of people do this. We have like a TURBT plan, right? To make sure that they're urinating a few times before they leave. Sometimes we hustle people out the door and then you get a call like, I'm in retention,
Yeah.
Some men really need a catheter. It's hard to pick who needs it. But the point of everything I'm saying is that we may underreport symptoms after TURBT or complications after TURBT that aren't really evaluated as much as we've evaluated everything else for quality of life measures. Because in bladder cancer, we're so focused on cystectomy quality of life, right?
Yeah.
What is this like? Or what is it like for the high risk patients who we know are getting these treatments that are irritative, right?
Yeah. My name is Dr. Ruchika Talwar. I'm a urologic oncologist in Nashville, Tennessee. Today, I'm joined by Dr. Charles Peyton, who's a urologic oncologist at the University of Alabama in Birmingham. And we're going to be diving into one of the most, I'd say, annoying disease spaces, intermediate risk bladder cancer. And, it's one of those things that falls in between the low grade that we tend to take a deep breath when we diagnose and talk our patients through what they can expect versus the high grade, which kind of rings those alarms and we know to take it seriously. Intermediate risk can be a tricky, nuanced situation. Before we dive in, Chaz, why don't you tell the audience a little bit about yourself?
Well, thanks so much for the invitation. I'm happy to be here. I've done one of these before, so maybe I got a little experience, but again, thanks for that invitation. Yeah, my name's Chaz Peyton. I'm a urologic oncologist at UAB. I've been here about 7 years in practice. I do the whole breadth of urologic oncology except for prostate cancer. I don't see any prostate cancer. So, a lot of my practice is bladder cancer, and I've participated in some interesting studies with some of this material. As a factor of disclosure, I think I probably should disclose at one time because this is relevant. Yeah. I did do a little consulting work with Urogen, but that was 2 years ago, and a lot of the stuff that I've published in terms of low risk non-muscle invasive bladder cancer was completely uncompensated. So that's my disclosure.
Got it. Thanks for that. Important. So I'm glad you brought it up. We will talk about the product that's out there, the reverse thermal gel that is used to treat this intermediate risk bladder cancer. But before we dive into that space, and obviously the topic that you brought up in terms of your conflict, let's talk more broadly about this disease space in general. I opened up by saying it can be really annoying, right? Because it is the recurrent, low-grade, non-muscle invasive bladder cancer that's pesky, that keeps coming back, that we often, didn't have enough BCG to treat. And as we have come to understand patient experiences regarding transurethral resection of bladder tumors, or TURBTs, which really were the mainstay of how we would address this, we've realized that, despite the fact that it has a favorable prognosis, there really is significant patient quality of life considerations to account for when we think about our treatment strategy. So let's just start in terms of your approach to a new patient you're seeing in clinic with recurrent low-grade non-muscle invasive bladder cancer. How does that conversation generally go?
Yeah, I think you're right. I think annoying is probably a reasonable word to describe it for both patients and providers, maybe. So, I think the conversation is like, okay, by the time they're coming to me, they've maybe had this a few times. It seems like usually the conversation starts as, okay, this does meet criteria to be a bladder cancer. The risk here is a high rate of recurrence. The progression risk is low, but not zero by any means. So surveillance is really important. And then how we approach the treatment, I think, is kind of used to be blanket the same way for everyone, but not so much anymore. I think patients have to know that it's generally a non-fatal disease, right? And it's something that can be annoying, like you said, and can have intermittent hematuria with these lesions coming up or symptoms related to that, particularly when the lesions are large. That's the problem. Now, I think in terms of where this disease is seen, it's a little skewed. I'm at a big tertiary quaternary, cancer center. And sometimes I think more often than not, a lot of these patients actually don't coming to the big referral centers. They stay in the community. And I think a lot of the trials actually speak to that because they're more community-based trials, which is important. These are the tumors that just keep coming back time and time again. And I think for a long time, we've been treating them just with intermittent surveillance techniques and ablations and whatnot. So yeah, I think the conversation, though, again, it's usually framed around the recurrence risk and less so about the progression, but not forgetting about that as well.
Yeah. And in these patients, when you talk to them about those repeated trips to the operating room, in your experience, I mean, how do you address some of the concerns regarding recurrent lower urinary tract symptoms, the risk of things like, repeated urethral trauma, urethral stricture development, and as you alluded to, hematuria, infection, and some of those things that we rattle off on the consent form without maybe thinking about too much, but that patients really have to deal with after surgery?
Yeah, I think first thing is to take a step backwards, and that the first treatment you try to do for these folks is not go to the OR and surveil them and treat them in the office. The other day I was just doing this, the guy with 3 or 4 little tiny, less than 3 millimeter little distals that we've biopsied time and time again. They're always low grade, and you just zap them in the clinic. And I think that's pretty standard for the low risk disease for sure. And then for some of the intermediate risk patients, that in my practice seems to be a little bit more frequent than the large volume ones that keep coming back. But again,
let me ask you a question
sure.
about that, though. Let's say it's a patient who comes back, it's a recurrence. What pushes you to want to take them to the operating room to biopsy it? For example, if you're worried about progression or something changing, I assume you'll send to cytology, but we know that's not perfect. So tell me a little bit about what would trigger you to treat it in the office or go to the operating room?
So I know my ability, I think, to do an awesome biopsy in the office is a little bit more limited than it will be in the OR. So if they have rapidly recurrent disease and symptomatic disease that's worse than you would expect, then those are the patients that I would definitely want to take back to the OR and get a good TUR specimen. That's where I would say. So, a lot of these we can treat for the very, very small little distals, like I said, in the office. It does take time to do that. And that's the other thing. If there's a ton of them, even if they're small, if you're going to, no one wants to spend, the patient doesn't want to sit there getting their bladder zapped 100 times in the clinic, and you don't have the time to do that. So in the OR, it's a lot quicker. So I would say, rapidly recurrent, high volume disease that's surprising, and then maybe symptomatic patients, and then maybe ones that won't tolerate it in the office, and then ones that have so many, even if they're small, that it's just, you're not going to get them all.
Yeah. Okay, now I had interrupted you there because we were going to talk about some of the quality of life changes after TURBT. So for the patients who you haven't treated in clinic, who need to go to the operating room, maybe who have had recurrent procedures, how does that conversation go in terms of, what are some things that the patients are worried about? What data exists out there to help inform some of these discussions we're having? And what are you most worried about?
Yeah. So, if you look at intermediate risk and the NCCN guidelines, although they've changed a little bit recently, what are the options? The option is TURBT, right? It's that's what you do, surveillance TURBT. Patients that are going back for repeat TURBTs, like annual or biannual TURBTs, certainly have risks that are inherent that we all know of. Just taking a patient to the operating room, there's obviously a small risk of anesthesia anytime you put somebody to sleep. There's bleeding risk. There's trauma to the urethra with large scopes if you're using a TURBT. We've all seen fossa navicularis strictures from someone getting scoped 100 times and a 26 French resectoscope in there 100 times. But in terms of the data, actually, my favorite recent paper, and this has been put out a bunch, is there's a series from Hopkins and some associated, this multi-institutional study, but they looked at this recently in about 160 patients, and we're trying to kind of characterize. We do TURBTs all the time. We kind of blow it off, right? There's just another TURBT. What's the real consequences of doing TURBTs? Do we underreport the symptoms after TURBT? And that study actually it's just a retrospective study, but a multi-institutional 160 patients. And they used a visual analog scale, I think, and then patient-reported outcomes and some scale measures there. And, 80% of people are reporting some degree of hematuria after their TURBT, which may or may not be symptomatic. That's not too surprising, right? but 33% report some sort of like bladder spasms that are uncontrolled or incontinence afterwards. And then the thing that was the most surprising when I looked at this is there's a 10% risk of an unplanned ER visit. So
10%. It's a lot higher than I would think. Yeah.
it's higher than you'd think, I would say. So because
Yeah.
usually when we're just hustling through clinic and we're telling them the TURBT and, whatever. But the reality is if you're having a procedure with a 10% chance you're going to come back to the ER, that's not great.
Yeah.
And, we institutionally, we've kind of, I think a lot of people do this. We have like a TURBT like plan, right? Now we got BNO suppositories.
Right.
they're
We got
all
them
going
back.
to like
We got 'em
BNO
back.
suppository. We all want to empty their bladder, do everything we can to make sure that they're urinating a few times before they leave. Sometimes we hustle people out the door before they're actually burning, and then you get a call like, I'm in retention,
Yeah.
Some men really need a catheter. It's hard to pick who needs it, but the point of everything I'm saying is that we may underreport like symptoms after TURBT or complications after TURBT that aren't really evaluated as much as we've evaluated like everything else for quality of life measures. Because in bladder cancer, we're so focused on like cystectomy quality of life, right? And
Yeah.
what is this like? Or what is it like for the high risk patients who we know are getting these treatments that are irritative, right?
Yeah.
So what about this group? And the surgeries alone is not necessarily just something benign. So
Right. And another thing that actually I had clinic today, before we recorded this. And so another thing that came up in a conversation with one of my patients just today was, he's like, oh man, I'm going to need to take time off of work for this procedure. And then I'm going to need my partner to take time off of work too, because they've got to drive me. And so there's all of these like treatment burdens that we don't even quantify in this data. The study you're describing is one example of that, but there are patients who may get 1 or 2 or 3 TURBTs a year, and that adds up. That really adds up. I also think it's a really sensitive thing to talk about a scope going in your genitourinary tract, right? So there's like anxiety. You have 1 ER visit from your last TURBT. You're really not looking forward to your next one. And so I think there's just a lot that we don't even quantify, not to mention the financial implications, right? What are some of those financial implications that you're thinking about outside of maybe just direct cost to the patient? What about like to the system?
Well, yeah, I mean, of course, we've like characterized bladder cancer as like one of the most expensive, like long-term malignancy to deal with. Maybe even, I don't know that this is true, but like dealing with somebody with non-muscle invasive bladder cancer for 10 years may be more expensive than dealing with somebody with a muscle invasive disease you just cure.
Yeah.
I don't know that that's true, but like that's my statement there. Anyway, but yeah, I think people take time off work. They have to have a driver. All these sort of disruptions, and it's more true. And obviously, people that are younger. So actually, the patients I've had that have been interested in doing something different are actually young. They're younger. They're full-time working, doing something.
Yeah.
The other thing is, anytime somebody's anticoagulated, you got to think about that. You got to go off your anticoagulation, go back on it, stroke risk, blah, 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 all that sort of stuff. So lots of things to consider that, we do routinely, but maybe don't think about as much.
I totally agree. I think especially in the patient who's on anticoagulation, has a cardiac history, a TURBT is a TURBT until it's not. And so when it's like, it needs to be done at the main OR with cardiac anesthesia, and they've held their anticoagulation and they're in heart failure, and it's like even a simple TURBT turns into a big deal for the patient, let alone the one who needs to get pre-admitted for the heparin drip and all of that. So
oh Lord,
I
doing
think,
that.
yeah, I think there's a lot. So now let's talk about some of the alternative options. So we obviously have talked about the burden of TURBTs. You've shared a bit about who you would consider surveillance or office-based approaches for. And then we have this new option out there, Zasturi. And you alluded to the fact that you've done some work, both in consulting and some research work, looking at quality of life in patients who have opted for Zasturi. So tell me a bit about your thoughts first on the product, like what kind of value it adds to our current armamentarium, and then we can talk a bit more about how it might, address some of these quality of life issues we've talked about so far.
Probably the thing to highlight here is that, like, we can talk more about this in a minute, but the intermediate risk, like, spectrum is pretty heterogeneous, and there's been a movement over the last few years to figure out, like, who may benefit from this in the low risk category and which patients are well suited for that. So I think that's the first thing to think about. So this International Bladder Cancer Group, the IBCG group, has kind of really taken this on and to recommend, who's the best and kind of tiering, taking the intermediate risk category and then adding risk factors for each one of those. So this office-based people are like, you can fall right, whatnot. And then if you do your TURBT, you consider for a single dose installation of post-op chemotherapy. But then for maybe 1 to 2 risks, you got to think about kind of other options. And I think some of the data with this story actually came out before all that. So they were specifically looking at low-grade intermediate risk non-muscle invasive bladder cancer. So the group for which is studied is a little heterogeneous, and it's not necessarily characterized based on these risk factors that we've now seen that the IBCG is coming up with, which are like typical things. There is early recurrence less than a year, frequency of recurrence greater than 1 year, tumor size greater than 3 centimeters, but actually characterizing in multiple tumors. That's like actually characterizing that's probably important. So the data for I guess we can use trade name for UGN 102 or the story, whatever you want to call it, is a little heterogeneous. I mean, that was all over the place because we were just using our typical AUA guidelines. Even the NCCN has changed to kind of follow more of this, like better characterize what we need to do in that space. But to answer your question, where I think this fits as an option, right? An option. It's not better than, greater than anything else. So typically our guideline option is going to be either to locally resect these tumors and then observe them and then do that when they come back up. If they have 1 to 2 risk factors, like I said, we could do an induction course of BCG and whatnot. So the benefit here to this product like the story is that it's chemoablative. It's that you skip the OR altogether, right? We scope them, we see it, and then we put the medicine in there for an induction period for 6 weeks, just like we do for anything else. And that's it. You're not necessarily scraping these tumors out. So I think for a patient that you don't want to take to the OR, that's sick of going to the OR, that maybe has anticoagulated, that doesn't need the risk of coming on and off multiple times, or it's maybe more convenient for them to just go in the office, you can use this. So, I mean, the way I think about it is for patients that like refuse or would be better treated in the clinic. I don't necessarily think that there's any way we could say that one is better than the other at this point. And the data doesn't support that. It's an option.
It's not a substitute.
Correct.
It's an option.
It's an option and no more than that. It's a very expensive option.
Yeah.
So that's the other thing is that, we can dedicate a whole nother podcast to that.
Yeah. No, it's true. It's not for everyone. I think that's really important to remember. But I think, personally, again, I go back to that one, the true story of the patient pre-admitted heparin drip, taken to the OR, had to restart the heparin drip, do a bridge back, had recurrent hematuria. A TURBT led to like a 10-day hospital stay for intermediate risk bladder cancer that was symptomatic, right? He was having recurrent hematuria. So it's just another thing to consider, I think. But the other thing I wanted to ask you was, we've talked about quality of life, and I know you've done some work looking at quality of life, in patients who were on the trial evaluating UGN 102, the ENVISION study. So tell me a little bit about that and what are some points that we can glean in terms of how we counsel patients.
Right. So, we, with cystectomy, with prostatectomy, all this stuff, we've done plenty of patient-reported outcome data. So the same has not necessarily been true for non-muscle invasive bladder cancer, and particularly when we have treatments that are new in this space. It's never really been pioneered, right? So there's 3 studies that have been focused on UGN 102. And in all of those studies, patient-reported outcome data was collected. There's 3 different approved questionnaires that were collected there's a quality of life NMIBC, QLQ, NMIBC 24, that's the name, I think. And there's that one, and then there's our Core 30, which is a general questionnaire, and one other one. And all of these were collected, and the collections were pretty good across the studies. Now, we can sit here and nitpick those 3 studies if you want and talk about what happened with some of them. And then the comparative arm in the ATLAS study was like halted, and there's all sorts of things that we can nitpick. But the reality is the patient-reported outcome data is kind of superfluous to some of the effectiveness data. So I got involved in kind of looking at this, and we said, okay, well, we need to accumulate these questionnaires and look at them over time across all 3 studies and see what happened. And for the most part, while patients were on treatment, some of their symptoms, according to the questionnaires, got a little worse. But then afterwards, in the follow-up period, they recovered fine. And when you look at quality of life questionnaires and whatnot, there's something called the minimally important difference, the minimally important clinical difference in a scale. So we never established that really for these questionnaires. And what that tells you is like, yeah, it's easy to prove a statistical difference at 2 time points for a number, but the number doesn't really matter if it doesn't reflect a clinical change. So you're looking for like a threshold or a magnitude. And so we calculated those, and they range between like 8 to 12 points, somewhere in there, depending on the symptom that you're looking at within the questionnaire. And so basically, those changes that we saw during the treatment, they weren't necessarily clinically meaningful, although they did get a little worse number-wise. Only intermittently were they. And then across the studies, everyone got kind of better once they stopped the medicine. And it basically, the long and the short of it, this kind of review and interpretation showed that the patient-reported outcome symptoms were indicative of low patient-perceived symptom burden during this treatment. That's the easiest way to say it. There's no real comparative data. It would be really nice if we had like a TURBT arm and we could compare them. Now, there is some of that in the data, but you can't tease it out. It's not enough to really compare the two of them. And the Atlas data has some issues with it in that, I won't go into it, but there's some issues of when the treatment occurred and when the TURBT was done and this sort of thing. So we can't really do that. That would be nice to say like, hey, is it any worse? Is it better than TURBT? Well, we can't say that, but what we can say is that the perceived symptom burden and changes in quality of life were similar, if not better, than they were previously. And actually, that is one thing I should say, is that sometimes once they finished treatment, the symptom burden was even less than it was beforehand, which is what you would think would happen if you're having these recurrent tumors that we know cause symptoms, and now they've been ablated and they're kind of gone. That's really a lot of the work that was done with this.
Right. And I thought it was interesting in the subgroup analysis of the ENVISION study, they asked patients to compare prior experiences with TURBT. So obviously there's recall bias, like we have to acknowledge that. But I thought it was interesting that most patients did end up saying that they preferred the chemoablative approach. There were a couple of patients who said, hey, I actually prefer the one-time TURBT to needing to go in once a week for 6 weeks. But I thought that was an interesting point, because I could see that going either way based on my anecdotal experiences with patients in the clinic. But I thought it was interesting, as you alluded to, the fact that in their recall of prior experiences with TURBT, there were no big differences in urinary symptoms, in sexual functioning symptoms that were assessed. And so I think that gives us helpful information with which to counsel patients, because anytime we tell them about a new option, they're going to say, okay, I've had TURBTs before.
Why is this any better?
Yeah, exactly right. Why is this any better? Why is this any different?
I don't know if I can say it's better from this. I can say it's probably no worse. Your symptoms may actually be better than what they are on treatment afterwards. I can't say that it's comparatively any better than TURBT, and I think for the right patient, this may be a preferred approach. Someone coming to the clinic once a week may be easier for some patients rather than having a TURBT and taking a whole day or two off of work and then the symptoms related to that. So.
Yeah, exactly. And the anesthetic, I mean, we talked about those patients with all of those comorbidities. We didn't talk about repeated anesthetic burden in elderly patients and patients who might have cognitive decline, things like that. So I think, again, as we've said, for the right patient, it makes a lot of sense. Let's talk more about this idea of like doing less in bladder cancer overall. So we focused on intermediate risk disease. We've talked about surveillance. We've talked about doing some of these procedures in clinic to either fulgurate or biopsy or whatnot. Now, shifting into patients who might have higher risk disease, I'm curious just your experience in general in the clinic. May not be data-driven or whatnot, but tell me about who you feel comfortable managing with surveillance with a, for example, small solitary high-grade tumor.
So any patient that we characterize as low risk, I usually feel fine about as just watching it.
What's the upper limit though?
Well, I mean, a solitary tumor that's come back after you've known that they've been low grade, low risk before, and then they have another solitary tumor that's small, I feel comfortable offering to the patient, hey, we can watch this, or I can take you to the OR and resect it, or if it's small enough, I can just take care of it right now. I think that if you have, multiple tumors that have recurred in less than a year, that's where you may want to like treat them. The trick is when to like rebiopsy them, right? What triggers that? None of the IBCG like algorithms and stuff are really telling you like necessarily, not that I know of, maybe I need to look at them closer, but they don't necessarily tell you like when do you need to rebiopsy these people, when are they at risk of becoming high grade. But I think if you're having like multiple tumors, multiple recurrences within a year, then yeah, like I think you need a rebiopsy. The other thing we don't know is that if you go on a chemoablative treatment and you have a recurrence, what do we do then? Because, you know, there's not maintenance done in these chemoablative treatments. And the folks at Urogen are touting an 80% disease-free survival of the responders at 12 months. And the response rate at 3 months, I think, was around 70%. So I think what we'll notice is that like once we have somebody that's recurred on the ablation, we're not going to know what to do with them. So I would probably biopsy them and go back to the OR at that point. But okay, really, what are we dealing with?
No progression. We want to make sure there's no high grade.
Exactly.
I'm curious, outside of this context of intermediate risk disease, which patients with high-grade disease do you feel comfortable observing? Because we also take care of octogenarians, nonagenarians with bladder cancer in whom a TURBT is high risk, right? Not just the intermediate risk patient. There might be some of those guys too, or those women too. So who of that population do you say, okay, I feel comfortable dealing with this in the clinic? Because I think that's a challenging clinical scenario for a lot of people.
Yeah, it's funny. I was just the VA and I literally just had this patient. So these patients declare themselves. That's what happens. They have their TURBT and they don't somehow go through with any sort of treatment with BCG or whatnot. And then they maybe disappear and they come back 3 years later and they've got like a solitary recurrence that's easily treatable. I mean, okay, that makes me feel pretty good. It's been 3 years since you've had a tumor. The guy I just saw was 90. I was like, well, we feel, you know, you've done pretty well. Like you beat the odds here. You've had no treatments in 3 years and you've had one tiny recurrence. That would be somebody that you'd think about. Like to me, it's all about the recurrence patterns and the timing. That's why sometimes non-muscle invasive bladder cancer is really, really frustrating to take care of, particularly if you're like the third or the fourth provider doing it, because sifting through those records and like figuring out the timing is like, that is the hardest part of the job.
Yeah.
The timing to me is what is the most important thing.
Right. And as time goes on, these patients are getting older. They're stacking up comorbidities. And so I think it becomes a lot more uncomfortable. We haven't talked about this yet, but I want to pick your brain on counseling the patient who you might feel less is more in, but the patient might think, hey, I want to be aggressive. This is bladder cancer. When I was diagnosed 15 years ago, my urologist told me this is a big deal. How do you approach that scenario?
I mean, it's like any other clinical question. You got to paint the picture with context. You know, I routinely remind people that this is generally a non-lethal disease, and that, you know, every patient has like they land somewhere on their risk threshold scale. I mean, that's how I describe it. We talk about this in prostate cancer like all the time. I think that discussion may have some segues to particularly intermediate risk, low-grade non-muscle invasive bladder cancer, and trying to get an assessment from that patient what their risk aversion is. Now, you know, the cancer word is troublesome to some patient, and it may be elderly, have a lot of comorbidities and want you to take care of everything that they're doing. And the flip side of that is you are doing a TURBT, and we did talk about symptoms related to TURBT, which is a real thing. However, like in the grand scheme of like operating, a TURBT is a low risk operation.
Yeah.
So don't forget about that.
Yeah.
That's what I'd say.
Yeah. So you touched on this point earlier, which I loved and I think is so true. The majority of these patients with non-muscle invasive bladder cancer are taken care of in the community. They are managed in the community. And so when you think about launching some of these newer therapies, what's your advice out there to community urologists who might just be learning about Zosduri and thinking like, how does this fit into the grand scheme of things? Like if you had to sum it up in sort of a take-home message for those folks listening, what would that be?
Exactly what I said earlier. It's an option. This is an option. It's not for everyone. I think it's a reasonable option for the right patient. I think we will make U.S. healthcare way more expensive than it needs to be if we give this to every patient walking in the door that's qualified. So, there needs to be thought into doing it. The expense of this will inherently build some hesitation in doing it for everyone, because depending on your practice and how sophisticated they are, they're writing the check and then hopefully getting the reimbursement. So that's tricky. Now, with some sophisticated practices, they don't really have a problem. I mean, some of these practices have been doing this for ages, that we're used to taking care of like castration-resistant metastatic prostate cancer, because that's what paved the way for urology to flirt with being a medical oncologist and give all these sort of expensive medicines. So some practices can do this and it's not a problem. But this medicine, I think, has fewer indications than some of the other new agents that we have for high risk. And it's not where I would go first to try a new thing. But if your practice is established in doing it, then yeah. I mean, I'll tell you the truth. The honest truth is I have not pursued getting ZUSDURI approved at UAB, even though I was involved in some of it, because I just don't see enough patients. I only have so many asks, And so I reserve the ask for things that I think are going to be really fruitful and high numbers and going to help our institution. And, I'm comfortable with that. And I think our department's comfortable with that.
I think that makes sense, right? Because again, the majority of these patients, their touch points are in the community. They may not be at the tertiary care center. I think that makes sense. Here we do offer it. It's been helpful, especially in some of those complex patients. But to your point, I think there is a time and a space in a resource-constrained environment, which we all work in.
Right.
I think these are really important points, to consider.
Yeah. I mean, don't discount what I was saying. We would offer this. I have so many asks, and our community urology program at UAB is growing, and that's where it's probably going to fit.
Right.
The other thing is I like to keep options open for other trials. This is the truth. So that's the other thing, which we can talk about that too, because there's some other interesting stuff.
Exactly. So what's on the horizon in this space? What other trials are we looking forward to figure out what agents we might be able to add to this growing armamentarium of options? Yeah,
I was looking forward to this question because the most exciting one, there's a ton of them, but the one that is the furthest along is going to be the TAR-210, which is the erdafitinib releasing TAR device, right? The bladder pretzel made by Johnson & Johnson. So that one's really interesting because we know that a lot of these low-grade tumors are going to express FGFR. There's some preliminary data showing that actually it may be equally as effective, not equally as effective, but effective in patients that actually don't have the EGFR expression phenotype. We saw that with PD-1, PD-L1 expression and pembrolizumab years ago. And then we realized not everyone has to phenotypically express it as much when you do the IHC for it to be effective. So anyway, the TAR-210 is pretty interesting because it achieves something that the installations don't, in that the device goes in and it stays in for 12 weeks. So that's different than the TAR-200, which is going to be exchanged every 3 weeks. The TAR-210 device is a slow release of erdafitinib, and the whole device is actually different. There's a nitinol vial in TAR-200. The nitinol's gone. It's a piece of plastic on the inside. I can't imagine how much it costs to design that little piece of plastic, but it's a little bit of a different device, a different design. The way it works is different from the osmotic pumps and whatnot. But it's a pretty interesting trial. That trial is finished. Moonrise, there's a series of Moonrises, and we're just awaiting the results. I treated several patients on trial with that, and the results were great from what I have. Specifically, I had a guy who was young, really young. He was like, I'm tired of having TURBTs. Is there something else? I was like, well, yes, there is. So we did that on him. He had, he's been doing fine. The other things that are out there, I think UroGen has a new formulation of UGN-102. It's UGN-103 that they're talking about. They're testing. There's a N803 or Ankiva formulary that they're trying on trial for low-grade disease. The Tyra 300, which is another FGFR3 selective TKI, I believe. I think that's how that works. That one has a randomized trial, and then there's I think there's a dose-dense chemoablative mitomycin trial called COBRA that is looking at low grade, and then there's a few others. Of course, one company does it, someone identifies the niche, and then the doors will bust open. So it's interesting. I think we all have to think and be careful about how expensive this is going to be, But, sometimes I think like, well, listen, our medical oncology colleagues have been doing this for a long time. They're spending all this money. So maybe, it's not so bad for us. But you got to think about it in the context of the cost to society and the patient as well in terms of, reducing symptoms and making it better. So some of these new medicines may work better than the other ones. And the chemoablative thing, I think they're all, pursuing with the chemoablative thing, avoid the OR, which I think it's a good movement because the more we know in this setting, then it will spill over into the other settings. So
yeah. And let's not forget, 60% of counties in America don't even have a urologist. So as easy as it is for us to get patients to the OR, it may not be that easy for patients to access, the operating room for a simple TURBT. So there's another, I think, use case for all of these different options that are out there to keep patients, outside of surgery. I'm personally hearing you and hearing all those options, looking forward to the biomarkers that follow, because I'm really hoping they can help inform, who gets what treatment.
Yeah, I mean, that's the holy grail, right? Like, oh, you're positive for this and you're low risk and you've come back, with multiple times within a year, then in your FGFR positive, we need to give you this and it will work. That's the holy grail. The timing of when to test your FGFR and how to get it, because you can do urine and you can do tissue. That data is coming out and to see how it correlates in the real world. Well, in the trial world, rather.
Yeah. Awesome. Well, super exciting space. Again, expanding, I'd say embarrassment of riches, for lack of a better term. It's really going to be an interesting few years, I think, in bladder cancer care, as it has been. We're just so grateful that you joined us. Thanks so much for sharing some of your wisdom with our audience. We appreciate it.
Yeah, thanks for having me. This has been fun. And yeah, I agree with you. The bladder cancer world is blowing up and there's no signs of it stopping. So
exactly.
We'll see what's on the horizon.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Deng.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening and see you next week.